Right. Okay, so yesterday we did the bulk of the interpretation of upper limb and lower limb neurology. So today we have only a few things to talk about. So remember that I told you that when you're localizing or approaching a patient with upper limb or lower limb neurological issues, you have to try to group your physical signs into one of 6 groups. What are the groups? Pure upper motor neuron signs, that's one group. Pure lower motor neuron signs, which is the other group. Mixed upper motor, lower motor neuron signs. And then extrapyramidal, cerebellar, and sensory, pure sensory. And we talked about all of these categories. And I focused a little bit on, we focused a lot on lower motor neuron pathologies yesterday. So today we are going to do the upper motor neuron. So right, that's what we are going to do today. So how we approach a upper motor neuron issue, right? Upper motor neuron issue. Right. Now, upper motor neuron is relatively easy because the possibilities are limited if you get upper motor neuron pathology. Right. Now, upper motor neuron lesions follow one of 2 patterns. Okay, so please write that down. So when you have upper motor neuron pathology, they are one of 2 patterns, right? One of 2 patterns. Okay. Number 1, hemiparesis or hemiplegia. Okay, hemiparesis or hemiplegia. Number 1. Number 2, paraparesis, quadriparesis. We usually bulk it in one, paraparesis and quadriparesis. So hemiplegia means one side of the body, face, arm, leg. Paraplegia, quadriplegia, what it stands for is paraplegia is bilateral lower limb weakness. Quadriplegia is upper limb and lower limb weakness, bilateral upper limb and lower limb weakness. Okay? So those are the main patterns of upper motor neuron lesions that you get. Very, very rarely you can get monoparesis in upper motor neuron problem. Say that is one arm or one leg involved, but that's not very common. That's not very common. Most of your upper motor neuron problems will fit into the pattern of hemiplegia, paraplegia, quadriplegia. A pattern get a fit. Right, and very rarely you get a monoplegia where it's one leg or one arm or something involved in upper motor neuron. That's not very common. Not very common at all. Right. Now, the approach to hemiplegia we'll talk about when we're talking about stroke. Right. So because almost always hemiplegia is due to some sort of stroke. There are exceptions, but let's talk about the approach there when we talk about a long case of stroke. So today the class is only on then how to approach a patient with upper motor neuron paraplegia, quadriplegia. How to approach a patient with upper motor neuron paraplegia, quadriplegia. Right. So the first thing is upper motor neuron lesions always follow a pattern. So they are either hemiplegia, that is one half of the body involved, or they are paraplegia, quadriplegia. So today we are going to talk about upper motor neuron paraplegia, quadriplegia. Okay, so let's talk about that. Right. Fine. Okay, so let's first deal with paraplegia. Right, that is lower limb, bilateral lower limb. Right. Now, when you have upper motor neuron bilateral lower limb weakness, okay, when you have bilateral upper motor neuron lower limb weakness, what does that tell you? What does that tell you? It tells you that the lesion has to be, upper motor neuron, the lesion has to be above the highest nerve root that supplies the lower limb. So if you have upper motor neuron signs in the lower limb, what that means is, so bilateral lower limb, so upper motor neuron signs theory, right? What that tells you is the lesion has to be above the highest nerve root that supplies the lower limbs. So what is that nerve root? That is L1. Okay, that is the highest nerve root that supplies the lower limb. Because it's upper motor neuron in the lower limbs, it has to be above that point. It has to be above that point. Okay. L1 එකට උඩින් වෙන්න ඕනේ. Right? L1 එකට උඩින් වෙන්න ඕනේ. Another additional thing is that actually below L1 there are no upper motor neurons ඇත්තෙත් නැහැ ඇත්තටම. They are all sort of bunched together as lower motor neuron. කෝඩා ඉක්වයින කියන හරියේ එතන upper motor neurons උත් වැඩිය නැහැ. They are all bunched together as lower motor neurons. හරි? So එතන කොහොමදත් තියෙන නිකන් lower motor neuron. So the lesion has to be above L1 because of these reasons. The main reason is if you have bilateral lower limb upper motor neuron signs, the lesion has to be above the highest nerve root that supplies the lower limb. එක තේරුණාද බලන්න. So L1 වලට වැඩිය උඩින් වෙන්න ඕනේ. Any questions about that? You have to understand that first. පැහැදිලිද බලන්න එක? ඒ කියපු කතන්දරේ. ප්‍රශ්න දිනනවා නම් අහන්න ළමයි. මේ බොහොම වැදගත් පාඩමක් ගන්නන්න. Okay, so absence silence means no questions. So hopefully you understood that. Right. So then you can conclude then if you have a patient with paraplegia, the lesion has to be above L1 in the spinal cord. Right? So if you have a patient with paraplegia, the lesion has to be above L1 in the spinal cord. The spinal cord එක අස්සේ තමයි upper motor neuron ටික තියෙන්නේ. Right. So that is where we start now. Now you can so I can make a statement saying, if you have a patient with upper motor neuron lower limbs, upper motor neuron paraplegia, the lesion has to be in the spinal cord above L1. So L1 will be spinal cord එකේ තියෙන්න ඕන. Paraplegia නේ කකුල් දෙක විතරයි ගිහිල්ලා තියෙන්නේ නේද? අත්වල මුකුත් ප්‍රශ්නයක් නැහැ. So that I can say my lesion has to be above L1 in the spinal cord. Okay, clear? ඒක තේරුණාද බලන්න? Fine. Okay. Right. Now, above L1 in the spinal cord is also a big area. Ne? Above L1 in the spinal cord. So patient has paraplegia. අත්වලට මුකුත් වෙලා නැහැ. So the lesion has to be above L1 in the spinal cord කියලා අපි කිව්වා. ඒකේ upper limit එක මොකද්ද? Above L1, below what point? Below what point? කියමු බලන්න. Below what point? අත්වලට මුකුත් වෙලා නැහැ නේ. paraplegia විතරයි ඉල්ලමයි තියෙන්නේ. අත්වලට මුකුත් වෙලා නැහැ. ඒ නිසා the lesion has to be below what is the අත්වලට එන යටම එක මොකද්ද? T1. So now the lesion has to be between L1 and T1. Between L1 and T1. හරිද බලන්න ඒක? So very simple. Say your patient has bilateral paraplegia, upper motor neuron paraplegia in the lower limbs. What you conclude is the lesion has to be above L1 in the spinal cord. Because the upper limbs are not affected, paraplegia kiwi, upper limbs are not affected, the lesion has to be below T1 because T1 is the lowest part that applies the upper limb. T1 වලට උඩින් තියෙන අත්වලටත් බලපානෝනේ. T1 වලට වැඩි උඩින් තියෙනවා නම් අත්වලටත් බලපාන. So අත්වලට මුකුත් වෙලා නැහැ. Now we know the lesion is between T1 and L1 in the spinal cord. Right. Is that clear? Any questions about that up to now? මම කැමතිම නෑ මේ පාඩම මෙහෙම උගන්වන්න, but there is no choice. I can't come to Sri Lanka and teach you this too. හරි. හරිද බලන්න? Is that clear? Okay, fine. Now, how do you localize it further now? Now we know the lesion has to be between L1 and T1. Ne? L1 T1 අතර වෙන්න ඕනේ මේ lesion එක. කොහොමද localize කරන්නේ? Very easy. Very, very simple. Use the sensory. Like T1, L1 අතරට මේක දාගන්නේ කොහොමද? Use the sensory. As you very well know, or hope you should know this, when there is a spinal cord problem, there is usually a sensory level. In about 70% of patients, there will be a sensory level. Hari? If there is a sensory level, very simple, you can say, okay, fine, the lesion is at the top of the sensory level. Say, for example, you have a patient with bilateral upper motor neuron paraplegia, arms not affected. Now you know the lesion has to be above L1 and below T1. Then when you examine the sensory, you find a sensory level at T6. T6. That is the level of the lesion. So now you can finally say, so madam or whatever examiner, this patient has a bilateral spastic paraplegia. The lesion is in the spinal cord at the level of T6 because that is where the sensory level ends. That is where the sensory level ends. Right? That is where the sensory level ends. So the lesion is at T6 of the spinal cord. Okay, fine. Okay, that is easy in 70% of the people because they have a sensory level. Now, the rest of the 30 sometimes in partial spinal cord problems, the sensory level like nati ayat tinnawa. So you have a spastic paraplegia without a sensory level. Right? That occurs in partial lesions of the spinal cord. Sensory එකට මුකුත් වෙන්නේ නැහැ. එහෙම වුණාමත් localize කරන විදිහක් තියෙනවා. ඒක 6 වෙනි සතිය උගන්වනවා. හරි, I will teach that in the 6th. Say there you have spinal cord decay but partial lesion එකක් නිසා sensory is intact. Then there is another way of localizing, still localizing, but I will teach that in the 6th week. Right. Then හරිද බලන්න paraplegia තේරුණාද කියලා බලන්න. Please ask any questions if you have. Right. Now, can we read this case 1 and tell me where the lesion is, please? So I just put it in a way that you might present a case. Somebody asked about case presentation the other day. So inspection, no wasting fasciculations, low limb tone is bilaterally increased, 4 out of 5 in all muscle groups, hip flexors, 3 out of 5. Okay. Knee and ankle reflex exert, but no clonus, plantar's extensor, and a sensory level at T10, joint position sensors also affected or abnormal. First of all, put it in the box. Is this upper motor neuron, lower motor neuron, mixed, extrapyramidal, cerebellar, or pure sensory? It's an upper motor neuron, right? Now tell me, and it's an upper motor neuron, and I'll also say that the upper limbs are normal. Normal. Now it is a paraplegia case, right? Now tell me where the lesion is. Me ගන්නව පාඩමෙන් කියන්න බලන්න. Lesion එක කොහෙද තියෙන්නේ කියලා.
Sir, T7.
T7.
Yeah, sir.
When you say T7, what T7 are you referring to?
The vertebral column, sir.
Yeah. So don't go by the vertebral column. When you are doing neurology, always stay spinal level. Don't worry about the vertebral column. Okay. I know in anatomy they have taught you that when it comes to clinical medicine, because anyway you're going to image the spine and you can diagnose where the vertebral body is or whatever. And remember, it's not always a vertebral problem. It can be an intrinsic spinal cord problem. So always go by the spinal level. Okay, so if you go by the spinal level, very simple. What is the spinal level? T10?
T10.
Yeah. So you can clearly say this is a lesion in the spinal cord at the level of T10 here, right? No problems, right? Any questions about this? So that's simple. Even there are rarely you might not get a sensory level in partial spinal cord problems, and there is a way of localizing in that instance also, which I will teach you later in the 6th week. Another thing I will teach you in the 6th week is there are various types of spinal cord syndromes also. So you'll be able to diagnose some of these, whether it's inside the spinal cord, outside the spinal cord. ඒ වගේ දේවල් diagnose කරන්න පුළුවන්. ඒවත් 6 වෙනි සතිය උගන්වන්න. දැනට මේ basic එක ඔලුවට දාගෙන you have to practice this now, right? And then by the end of the 6th week, we put the icing on the cake, those slightly more advanced topics. Right? Okay. Now, any questions there? Right. Now let's learn about the quadriparesis. Approach to quadriparesis.
Excuse me, sir.
Yes.
Yeah, I have a question. If the patient says now, say the patient can feel at T10, but it's less than normal, then do you take that as a sensory level or the level at which it becomes completely normal?
Yeah, so there's always a bit of a transition zone where දැනෙන්න චුට්ටක් දැනෙනවා sort of transition zone. I wouldn't be so worried as to, so it's usually within one spinal segment, say up to T7 දැනෙන්නෙම නැහැ. The patient cannot feel at all. Then T6 පොඩ්ඩක් දැනෙනවා. Then above T6 he can feel very well. I don't really mind as an examiner or a clinician whether you say the level is at T7 or T6 or whatever it is. ඒක ලොකු ප්‍රශ්නයක් නැහැ. හරි? But usually හොඳටම දැනෙන්න පටන් ගත්තම තමයි අපි කියන්නේ that is the level කියලා. හරි? But it's not a major problem. හරි?
Thank you, sir.
Yeah. Right. Okay. So I hope that you understood that. Now let's talk about quadriplegia. So quadriplegia කියන්නේ මොකද්ද? lower limb upper limb දෙකම ගිහිල්ලා තියෙනවා කියන එක. Right? Lower limb upper limb දෙකම ගිහිල්ලා තියෙනවා කියන එක. Then again, very simple. ආයුක කියන්න දෙයක් නැහැ නේ. Sensory level එකකින් localize කරත හැකි. Right? So when your lower limb upper limb all are gone, the lesion has to be somewhere in the cervical cord. නේ? Lower limb upper limb ඔක්කොම ගිහිල්ලා නම් the lesion has to be somewhere in the cervical cord or above. Right? That is where the problem has to be. Right? If there is a sensory level, no problem at all. You can use the sensory level as the exact place. Right? So for example, if there is a sensory level at C5 or something, you know the lesion is at C5. Right. Now again, in quadriparesis also, there are a group of people who don't have sensory loss. Right? Sensory natuwa, just the motor. They have a spinal cord problem, but it's a partial problem. So their sensory is normal and there is no sensory level. Then එතකොට මොකද කරන්න කියලා අද උගන්වනවා. හරි? මම paraplegia එකේ කතන්දරේ කිව්වේ නැහැ, but quadriplegia වල ඒ කතන්දරේ කියනවා. හරි. Right. So you understood if it's quadriplegia, you know the lesion has to be in the cervical cord above. අත් කකුල් ඔක්කොම ගිහිල්ලා තියෙන නිසා. And if there is sensory level, you can easily localize it with the sensory level. But if there is no sensory level, which can happen, then we will learn how to localize it. Right. Then බලමු ඒක කොහොමද කරන්නේ කියලා. Fine. Okay. Right. Now look at this. Right. මේ උඩ හරිය පොඩ්ඩක් දැනට කතා මේවා කරන්න එපා. Right. Now, even if they don't have a sensory level in a patient with quadriparesis, right? In a patient with quadriplegia, even if they don't have a sensory level, you can still use various other ways of localize. So the scenario here is quadriparesis. If there is a sensory level, no problem. Quadriparesis, if there is a sensory level, no problem. If there is no sensory level, how do you localize it? Right, how you localize it? Step one. Examine the upper limb reflexes. Examine the upper limb reflexes. Upper limb reflexes. Examine. Now, I want you to think of upper limb reflexes. Biceps, triceps, supinator. Biceps C5, C6. Supinator C6, C7. Triceps C7, C8. Then my scenario දෙකක් කියනවා. Scenario දෙකක් කියනවා. දැන් මේක බලන්න කලින් කියන දේ අහගෙන ඉන්න. මේක පොඩ්ඩක් කියනකම්. හරි. Scenario 1. All the upper limb reflexes are brisk. That is scenario 1. All the upper limb reflexes are brisk. Everything. හරි. ඒක scenario 1. එතකොට දැන් මතක තියාගන්න patient has quadriparesis upper motor neuron signs ටික අහුවෙනවා. හැබැයි sensory level එකක් නැහැ. Sensory level එකක් නැහැ. How do you localize it? Look at the upper limbs. Upper limb reflexes තමයි හොඳම උදාහරණය ඔකට බලන්න ඕනේ. Say scenario 1 in this patient, all upper limb reflexes are brisk. Right. That's scenario 1. Right. Scenario 2. Scenario 2. Right. Scenario 2 is that scenario 2, biceps reflex is absent, triceps reflex is brisk, supinator reflex is inverted. මම ඒක තේරුම කියලා දෙන්නම් මොකක්ද කියලා. Supinator reflex is inverted. That is scenario 2. Right. Scenario 3, upper limb එකේ small muscle involvement විතරයි තියෙන්නේ. Reflexes normal. Upper limb එකේ small muscles are involved. None of the others are involved. Just the small muscles. Right? Weakness of the small muscles and the reflexes are normal. ඔක්කොම reflexes normal. Scenario 3 හරිනේ. Right. So quadriparesis without a sensory level. So now you are using other ways of localizing it. Right? 3 possibilities. Possibility number 1, all the upper limb reflexes brisk. Possibility 2, biceps reflex absent, triceps reflex brisk, supinator reflex normal, inverted. Scenario 3, in the upper limbs, the only involvement is the small muscles, and then the reflexes are normal. Right. Then කියමු බලන්න. Scenario 1, where is the lesion? So quadriparesis, no sensory level, but all the upper limb reflexes are brisk. කියමු බලන්න. Where is the lesion? මේ ඔක්කොම කියපු ඒවා exam එකට දෙන short case තුනක් මේ කිව්වේ scenario තුනට. හරි. කියන්න.
Above C5, sir?
Very good. So scenario 1, because all the upper limb reflexes are brisk and we know that the biceps is the highest one and that is C5, C6, the lesion has to be above C5, C6. Very good. Very good. So the lesion has to be above C5, C6. Right. Hurry. Fine. Scenario number 2. Today, lesion is above C5, C6. ඕකටත් පොඩි බේ icing කෑල්ලක් තියෙනවා ඒක මම උගන්වන්නම් 6 වෙනි සතියේ. පොඩි icing කෑල්ලක් තියෙනවා එතන. එතන ඉහාටත් පොඩි icing කෑල්ලක් තියෙනවා but දැනට ඔය ඇති. Right. Scenario number 2, biceps reflex absent, supinator inverted, triceps brisk. Lesion එක කොතනද තියෙන්නේ?
C5, C6.
Yeah. The lesion is at C5, C6 exactly. Why? Because the lesion is exactly at C5, C6, the biceps reflex is lost because that is now a lower motor neuron at that level. So biceps reflex is lost. The triceps is still brisk because it's lower down. And inverted supinator කියන්නේ ළමයි ඒක මේ කාටරි කියන පෙන්නන්න කියලා when you go to neurology boards. When you tap on the supinator muscle, when you do the reflex, there are 2 responses. One is flexion of the fingers and there is slight flexion of the upper limb. ඔය දෙකම වෙනවා. ගැහුවම flexion of the fingers and flexion of the upper limb at the wrists, at the elbow usually. Inverted supinator, there are various forms of it. The only thing that happens is the flexion of the fingers. Just the flexion of the fingers. Right? Or ගැහුවම fingers ටිකත් sort of extend වෙන වෙලාවල් තියෙනවා. But those are a bit slightly advanced. At the moment, inverted supinator for you for the moment in your first Montessori week is ගැහුවම flexion of the fingers only, not flexion at the elbow. That is inverted. And that pattern, absent C5, C6, inverted supinator, brisk triceps is very suggestive of a lesion exactly at C5, C6 in the cervical spinal cord. Right. Scenario 3, the small muscles of the hand are involved, but other muscles are okay. And the reflexes are normal. Then lesion එක කොතනද තියෙන්නේ? Where is the lesion?
T1, sir.
T1. Exactly. So the lesion is at T1 in the spinal cord. Right. That is very simple. Right. So, right. So approach to quadriparesis is very similar to paraparesis. Quadriparesis can both upper limbs and lower limbs are involved to a certain degree. What is the approach? If there is a sensory level, you can localize it with the sensory level, no problems. Right? If there is no sensory level, what do? You examine the upper limb reflexes. And there are 3 possibilities that you can get. 1, 2, 3. Possibility number 1 is all the upper limb reflexes are brisk, so the lesion has to be above C5, C6. ඒකේ තව පොඩි කෑල්ලක් තියෙනවා ඒක 6 වෙනි සතිය උගන්වනවා. Because above C5, C6, the lesion can be in the cervical cord, it can be at the foramen magnum, or it really can be in the brain stem also. මොකද එතනින් උඩනේ. හරි. ඒක අපි 6 වෙනි සතිය ඉගෙන ගන්නවා. Right? But at the moment we will say if there's quadriparesis with all the reflexes brisk in the upper limbs, the lesion has to be above C5, C6. Right? That is important. Scenario number 2, absent biceps, inverted supinator and brisk triceps. There we know the lesion has to be in the C5, C6 level. Scenario 3 is that quadriparesis. Now there is no sensory level. You can be prasnik because there is no sensory level, and that can happen in partial cord lesions. So scenario number 3 scenario number 3 the small muscles of the hand are T1, remember? Right. So eva vitara involved and the reflexes normal because there is none of the 3 reflexes are innervated by T1. C5, C6, C6, C7, triceps C7, C8. There is no reflex innervated by T. There is a reflex innervated by T1 but that is seen only, it's called the finger jerk. That's seen only if there is an upper motor neuron thing there. Right? ඒකත් ඔකට කාගට පෙන්නන්න පෙන්නන විදිය කොහොමද කියලා. Right? But there is no big reflex innervated by T1, so the lesion has to be at T1 there. Right? So that is how you approach upper motor neuron lesions in quadriplegia. Any questions? So just to summarize then, upper motor neuron patterns තුනක් තියෙනවා. Hemiplegia, quadriplegia, paraplegia, we usually take them together because the approach is very similar. And then monoparesis is rare. Upper motor neuron monoparesis is rare. Right? Hemiplegia we'll talk about during stroke. Paraplegia, quadriplegia, අපි අද ඉගෙන ගත්තා. Paraplegia is lower limb weakness, upper motor neuron lower limb, and then I taught you how to localize it. With a sensory level, without a sensory level. Without a sensory level, එක මම අද කරේ නෑ පොඩ්ඩක් complicated ඒක පස්සේ බලන්න. Right. Then quadriplegia, again with a sensory level, no problem, කිසි දෙයක් කරන්න ඕනේ නෑ. But if there is no sensory level, if there's a partial cord lesion and no sensory level, then you need to do this body fiddlery around with the upper limb reflexes. And there are 3 scenarios. All upper limb reflexes brisk, C5, C6 absent, inverted supinator, C7, C8 brisk, and then last one, all upper limb reflexes normal, and the upper limb, the involvement is local to the hands. අතේ විතරයි ප්‍රශ්නේ තියෙන්නේ. So there below the lesion is at T1 of the spinal cord. Right. Any questions? Naveen, I can't hear you clearly.
Give me now.
Naveen? Hello? Hello? Naveen? Any other questions? Sorry, Vinda?
We can hear you.
Yeah, Naveen, maybe his connection is not good. Want to ask a question, I think. Anyone else have any questions to ask? Right. Okay, now the last word is about mixed upper motor neuron, lower motor neuron issues. Mixed upper motor neuron, lower motor neuron issues. At the moment, remember, if you find mixed upper motor neuron, lower motor neuron issues, and there is no sensory involvement, the lesion is almost always due to motor neuron disease. Right? ඒක දැනට මතක තියාගන්න. අපි අර හැම group එකක්ම කතා කරානේ lower motor neuron කිව්වා, upper motor neuron කිව්වා, cerebellar extrapyramidal චුට්ට කිව්වා. Mixed එකේ එකම දේ මතක තියාගන්න. දැනට 6 වෙනි සතිය දාපු ඩි icing කැලලක් තියෙනවා ඒකටත්. But at the moment, remember that mixed upper motor neuron, lower motor neuron disease, when there is no sensory involvement, is almost always due to motor neuron disease කියලා. Because that involves both the upper motor neuron and the lower motor neuron. Okay. Right. Hari, any more questions? Right. Okay. Now we have gone through about 80% of all the neurology that you need to know for short cases when it comes to the exam. Arituru vissa we'll do in the 6th week. Slightly more complex cases api karano. Hari. පොඩ්ඩක් කියනකො මේක තව example එකක් තියෙනවා. මේක කියන්න බලන්න. Where is the lesion? Okay, so while you think about that, Naveen is asking in the exam, if you are given a lower limb case, then do we need to examine the upper limb in order to find out whether it's quadriparesis or paraparesis? And then to further localize. Very good question, Naveen. Then exam me kiyanne upper limb, lower limb dekama balanna kiyala. Hari? You are asked to examine the lower limbs, right? You are asked to examine the lower limbs. So, and then say you find upper motor neuron signs in the lower limbs. The question is, should you examine the upper limbs also to find out whether it's a quadriparesis or paraparesis? That is the question. Now, Naveen, because you asked this question, I'll give you an example. Say if you examine the lower limbs, you find a very clear-cut upper motor neuron paraparesis and a sensory level at T10. Now, Naveen, in that patient, do you need to examine the lower limbs? The upper limbs, sorry. You don't know, because you're pretty well damn sure that it's in the it is in the T10 spinal cord level. Say you get another case, bilateral lower limbs are spastic, but no sensory level. Then put case. Sensory level, you're not really sure is this a quadriparesis, paraparesis, sure because sensory level in that case, Naveen, you have to ask the examiner, can I know if the upper limbs are involved, or can I examine the upper limbs reflexes? You need to offer that examination to the examiner. So it's slightly, and this is again something I would teach you in the 6th week, but because you asked the question, your point is very good, your question is very good, because can lower limb examine karanni. Lower limb case sensory level upper limb don't worry about it. Right? No point in worrying about it. Right? But if do the lower limbs and they are brisk and then case, then sensory level sure then ask the examiner, can I examine the upper limbs to confirm that this is a paraparesis, or if the upper limbs are involved, it could be a quadriparesis. So it's got a reflexes. Is that clear, Navi? So not all the cases, selected cases will take a current. Yes, fine, good. Right. Now, where is the lesion in this case?
So C5, C6?
Yes, exactly. So, lower limb it passe upper motor neuron signs, and then the upper limbs biceps reflex was absent, triceps brisk and supinator inverted. This is the exact short case you can get for the exam. And then you will say exam level is at C5, C6. Right. That's it. Very good. Right. So we have finished neurology now, or 80% of neurology now that you need for the exam when it comes to clinical neurology. So cranial nerves, then we did the lower motor neuron thing yesterday, started talking a little bit about the mixed pathology yesterday. And today we did the upper motor neuron patterns and how to approach upper motor neuron lesion in the upper limb and lower limbs. That is it. Right. Now what I want you to do is, please, you have to take the maximum use of the medicine appointment. Medicine exam during these 8 weeks, intense study, right? So what you do is go to the neurology wards, right? And maybe even the neurosurgery wards, but patients are difficult to find there because they right? Go to the neurology wards, talk to the senior registrars there. All of the buggers who are in neurology are my students. Right? So all of the people there, SRs I have taught at some point in their career. So you go and speak to them, tell that I asked Mama Kiwa to find you good cases to examine. Cranial nerves, upper limb, lower limb. Please see those patients. The more you see, the more you will see these cases coming up, and then discuss amongst yourselves how you are going to localize the lesions. Right? Lanka group neurology, but obviously again I can't do that from England. And because Harsha is no longer there as well, so Harsha Disanayaka, so there is nobody to do that sort of thing for you anymore. So unfortunately, you will have to do some self-work on this. But all the registrars in neurology, Shiran Paranithan kelekkenno, Medini kelekkenno, Shanya Gudasekara kelekkenno, and there's somebody else also. All of those buggers I have taught at some point. Undergraduate, postgraduate, Uganda. So Maganama Kepu Kama, Ula to Dokarai. So go there, see patients, don't harass patients, but learn, go through these things, and then collect a set of cases so that we can discuss them. Hayaveni sati enakota ogolo dakina short case tika yutta liya ganna physical science one, especially neurology. Also, if you can get the patient's concept, record it, video ekak ganna. That will be much easier for us to discuss. Hari, මම කියන 6 වෙනි සතියේ මම ආයෙ මේක කරනවා කියලා. ඔයගොල්ලෝ පොඩි collection එකක් හදාගන්න as a group. Again, patient consent ගන්න and don't make the patient pain මූණ පේන්න තියන්න නැති වෙන්න, recognize කරගන්න බැරි වෙන්න. Tell this for educational purposes. Don't share it, put it on YouTube or anything like that. But get a collection of cases in the neurology wards, and then we can go through them when we do the 6-week classes. ඔයගොල්ලන්ට පෙන්නන්න පුළුවන්. Then I can say, okay, this is the lesion. මෙහෙමයි මේක approach කරන්න කියලා. හරි? ඒක කරන්න පුළුවන්. Naveen, can you appoint somebody to coordinate that? Okay, so get that ready because අනිත් systems එහෙම කරන්න බෑ. Neurology පුළුවන්. Because neurology පේනවනේ වෙන දේවල් ටික science ටික මූණට පේනවා. So if you get a recording, I can sort of discuss that case, right? So please, you have 6 weeks to do this exercise. Collect කරලා අන්තිම ටිකේ discuss කරමු. Okay, right. Fine. Right. So then have a nice rest of the Aurudu day, and then I will see you. Oh, Naveen, then when are we going to do? Shall we then directly start on Monday? Because now we have to go to the long cases, and I don't think you have enough cases. You don't know what the hell is going on. So can I leave you for tomorrow and then collect the cases for Monday? Can you send me a message on Sunday with a list of the cases that are there in the ward, and I'll tell you what we are going to discuss. Okay, right. Hari. So I will see you on Monday then. Hari. Okay.